Thank you very much, and thank you for inviting me, and it's great to be back. We were in lockdown last time we spoke, Sue, so it's a real privilege to be here today, and welcome everybody who's joined us. So I'm going to just do a snapshot of personalised midwifery care and actually lead you and signpost you to many resources. Just share my screen. Sorry, just frozen for a minute. We did practice this beforehand. And it's not moving, so just give me a minute. Technical support. Just not able to move the slides at the moment. Shall I stop sharing and share again? I think that's probably it. Excuse me a minute. From beginning. Slideshow. Beginning. Let's try this. Yes. Okay. Sorry about that. There's always a blip. So yes, it's Epilepsy Awareness Month. And why is it important to be talking to you all today? Well, there is approximately 2,500 women per year with epilepsy who give birth. And so you'll probably come across at least one person within your practice, and it's an opportunity to learn more about epilepsy. But when you meet that person, you won't know what type of epilepsy they've had and what sort of experience they've had regarding their epilepsy. But we do know there is an increased risk of premature death in people with epilepsy, and the mortality rate in pregnancy and for 12 months following pregnancy is 10 times greater than the general maternity population. And particularly when we look at sudden unexpected death in epilepsy, when we do the embrace reports and chapter group writing, we're always astounded by how many women actually pass due to sudden unexpected death in epilepsy. And out of 17 women with epilepsy, 14 of those died due to SUDEP in 2019 to 21. So when we look at risk factors for SUDEP, we know age between 20 and 40 is a great risk. And of course, that's when a lot of our maternities appear. And also understanding risk isn't constant. So you might risk assess somebody at the beginning of pregnancy, but that can change even just 4 weeks down the way. We also know that the highest risk of SUDEP is somebody having tonic-clonic seizures, especially if these are prolonged or if they occur from sleep. And we always say avoid lone sleeping, lone and prone sleeping. Certainly in my practice, I've been seeing more people with learning disability having babies in the last few years, and they are at increased risk of SUDEP due to multiple reasons. We also see reoccurring features such as obesity and multi-comorbidities, and certainly people from vulnerable backgrounds. But the most recurring feature in epilepsy deaths is non or poor adherence of anti-seizure medicines. And this may not have been due to the woman actually stopping the medicine. It may have been a health professional who's advised them to do so, or they may have recently transitioned from a different anti-seizure medicine and the current medicine isn't providing the same seizure control. And also fragmented care. And this is where midwives come into play, because midwives can be the essential conduit between all the services, because they're the ones who can outreach. Now, when you meet a woman with epilepsy, I want you to think about the journey that's gone before them, because not everybody with epilepsy will have had the same experience. They would all had it for different lengths of times. The diagnosis may not be sound, because many people can be misdiagnosed with epilepsy or non-epileptic attack disorder characterized by dissociative seizures. You don't know what type of seizure they have. You don't know the frequency. You don't know anything about their risk behaviours. And you don't know how epilepsy has affected their education or employment. And also the gynecology effect. You know, have they had a problem with fertility? And also if they're from a different ethnic origin or they're from a different country of residence, they may have all sorts of stigma that has come with them as well. And also it's going to be reliant on their support network. I want you to consider the impact of that journey. Now, most certainly, this does not apply to everybody, that they have a multitude of stuff that goes on that's negative, because I'd say at least 60% of my patients don't experience negativity with their epilepsy because they've had good care. But not everybody's had this journey. Sometimes, as a result of their seizures, they've developed post-traumatic stress disorder, or they can develop that as a result of all the potential things that this could put them at risk of, including status epilepticus, an increased risk of sudden unexpected death in epilepsy, and also risk of drowning. And people saying, no, you can't do that. And of course, if you've got ongoing seizures, you can't drive, and that limits what you can do. That might affect your employment or your education. And you're prescribed anti-seizure medicines that potentially interact with contraception, so maybe more likely to have an unplanned pregnancy, but also this underlying fear of having a baby with birth abnormalities or syndromes. And it may be that your patient has already had children, and it may be they have had a child affected by their particular medicine. Certainly for some people with epilepsy, they suffer stigma and loss of independence, and with that becomes dependence, because they feel disabled, and they can, in some cases, end up in relationships that can become coercive. And of course, there is also a suicide risk, and that can be related to the medicines itself, or it can be related to their circumstances. So when you see a woman, I don't want you to just hone on epilepsy. I want you to think of that mum, that future mum, as an individual with her own story and her own history and her own experience of epilepsy. I want you to understand her concerns and risk factors and work with her to reduce adverse outcomes, because you're going to be at the beginning of her journey, mostly. However, some epilepsy specialists, such as myself, get to know before the midwife does, because the women let us know. So to help you with this process, I've designed a maternity epilepsy toolkit. It's been an iterative process, and please, if you have any feedback, I'd love to hear it, because then I can adopt it to your needs. So this is all designed around the needs of women and their families, other health professionals, but also feedback that I've had, and being an Embrace assessor for nearly 8 years. And so all the wisdom that I've learned from that, I've been able to instill into the toolkit. It is on my website, that's desperately needing to have an update, just that it's more compatible with phones, but all the information is there. Now, when you're at the booking appointment, if you find out somebody has epilepsy before the booking appointment, it's an opportunity to alert the obstetrician and neurologist or epilepsy specialist. But if you didn't know before this woman disclosed that she has epilepsy, then please make an immediate referral to the obstetric and neurology team for triage and categorization of risk. Now, I can't be explicit about this because some people have a team that come to the obstetric unit for a joint clinic. Other times there may not be a permanent neurologist or epilepsy specialist, such as on the Isle of Wight. So, you know, I don't actually know your circumstances, but if you don't have that facilities, we have the maternal medicine networks now where you can refer. When you take the history and you make the referral, please include the type or a description of the seizures. The woman might not know what they're called, or she might have her own pet name for them, but what she can do, or her partner can do, or family member, is give you an explanation about them. Please find the date and time of the last 3 seizures. This is really relevant because of the fact that if a woman has had seizures in the last year, she's potentially at higher risk of seizures during the pregnancy. I want you also to find out about the anti-seizure medicine that she takes. Have a good conversation about that. Find out the dosage, not only the time she takes it, but how she takes it. How does she remember to take it? Where does she obtain it from? And how does she ensure that she's always got a prescription? And it's at this point you can contact the neurologist or epilepsy specialist just to find out whether they want an anti-seizure medicine serum level, such as lamotrigine. Find out the other medicines she's prescribed, including over-the-counter, and whether she's taking folic acid 5 milligrams or 400 micrograms. Find out what's relevant for your trust, because ours is still 5 milligrams if you're taking anti-seizure medicines, but it does differ around the country. And if known, find out the name and location of the consultant neurologist and epilepsy specialist nurse, because it may be that the woman in front of you is delivering in a different unit, but you'll still be able to have the support of this woman's neurologist and epilepsy specialist, which is very important, but I would always advise to refer to your team as well. So how can you reduce risks? Well, because I like to base everything to women to help them take control, because at the end of the day, they are the decision makers. We call it shared decision with what they do, but it's their decision at the end of the day. And so when I get people to risk assess, I try and get them to risk assess themselves. But if the woman hasn't had the opportunity of doing this, you could just go through this list. And if you highlight anything, this list increases risk of morbidities and mortalities. And that's why I've got 20 pointers here. And I would just like you to include any of those which the woman answers yes to in your referral. So for instance, the woman was taking sodium valproate or topiramate, but she only actually stopped it 4 weeks ago. Well, that's really relevant because of the fact that she hasn't had at least 6 months on her new anti-seizure medicine. Or if she has focal epilepsy, she could be at increased risk during pregnancy, or tonic-clonic seizures from sleep. So, of course, you know, these will all then trigger the triage. But what you need to know as well, this is all in the guidelines, including the RCOG guidelines, but also the epilepsy guidelines, that women should be referred to a specialist. And it seems actually, doesn't everybody do that? Well, no, they definitely don't. Some women, I don't know if they've disclosed that they've actually got epilepsy, but it hasn't got into the records and they've never been referred, which is so tragically sad. So for yourselves, if you're community midwives, particularly, you'll be providing regular planned antenatal care with the community midwife and designated epilepsy care team. It's very important for midwives to put women down a primogravid pathway rather than a multigravid pathway, where some of the appointments are missed, because the woman needs robust support from everybody. And at each maternity, neurology, epilepsy encounter, a woman's risk factors should be assessed. And this includes sleep deprivation and stress. And, you know, sometimes, especially if you've got a little one as well, that's really hard to avoid, but you can work with the family to try and help with that. Find out about adherence to anti-seizure medicines, not just on the first meeting, but subsequently too. And also the seizure type and frequency, particularly if they're occurring in pregnancy. And I really want to focus on following up non-attendance. I think midwives are in the fortunate position to be able to outreach to women. Some women in some communities, particularly if they don't speak English very well, can be really reticent to come forward. And remember, they probably cannot drive either. And you might need to go to a place of worship or get in touch with somebody's aunties, as they're called in many African communities, in order to be able to locate and be able to support a woman with epilepsy from a vulnerable community. It's important to provide safety, water safety and safe sleeping advice, and that's all in the toolkit. So that's safety with bathing, safety with swimming, walking next to rivers and streams, etc. And when you're giving safe sleeping advice, remember not just to presume if somebody's got a partner that they sleep with them. Many people sleep apart, and it might be one person's upstairs and the other downstairs, or the partner always falls asleep on the couch. So remember, it's much safer to be sharing the bed with someone. And if that isn't possible, then it may be, and you can't get the person to be, if they are at risk of seizures, with a family member, it may well be you need to do a needs assessment through social care. If the woman does disclose any tonic-clonic seizures arising from sleep, that needs to be flagged urgently to an epilepsy or neurology specialist. And if the woman discloses recurrence of seizures, or she stopped her anti-seizure medicines, you need to obtain immediate, and when I say immediate, I mean if this is Friday late afternoon and you find out a woman has stopped her anti-seizure medicine, this is a red flag and you need to be letting everybody know immediately. Obviously, you need to talk to women about consent, about information shared, but to actually ask her about her decision making, because it may be that she's too frightened to take her anti-seizure medicine because she's worrying about the potential harm to her developing baby. So she needs to be counselled appropriately. Now, to help you in the toolkit as well and to be up to date, this time I've added QR codes, and they will help a woman navigate the pregnancy journey. And it includes the RCOG Epilepsy and Pregnancy, and how the woman can self-register to the UK Epilepsy and Pregnancy Register. And they are enrolling some women to research as well. Also encourage women to download the EPS1 app so they can self-monitor their own risk factors, and it gets you to update every 3 months. It's a great opportunity to talk about first aid for seizures, and you may be the only one as midwives to actually have the partner in the same room where you can actually demonstrate first aid for a tonic-clonic seizure or for a generalized absence or focal seizure. And if you do not know that information, please also go on those links yourself in order to find that out. And there's obviously great information on Epilepsy Action website about epilepsy and pregnancy and looking after a baby. And I've had the privilege of helping with this for many, many years. And also there's a link to my website and advice about contraception. It's important you give accurate contraceptive advice because of the fact many of the hormonal contraceptives interact with the anti-seizure medicines. But I cannot emphasize enough, safety and risk awareness should be discussed at each maternity encounter. But I want you to ask the woman's narrative about her risk. What does she do to try and mitigate risk? Because this isn't about you, this is about her. And she does know so much more about her epilepsy and how she keeps herself safe than you do. So please ask her first before you start giving her the information. There's also information within the toolkit to help with the labour discussion and the postnatal checklist. And for this one, because I used to just leave a blank S-bar on the toolkit, I found that many people don't know where to start with an S-bar. So situation, background, assessment and recommendations for when they're actually writing it for someone with epilepsy. So I've done a mock one that can be cut and pasted, particularly onto the electronic records, just to help people out. Because I have just retired from the NHS, but as Sue said, not stopped working. So what to consider postnatally? Remember, there needs to be an antenatal plan already set in stone before the baby delivers, in order that can often start from 3 days postnatal. The adjustments, if the medicines have been increased during pregnancy, and give accurate advice about breastfeeding. You can get that all from ToxNet. Stress the importance of continuing anti-seizure medicines, not missing doses, because this can lead to seizures. And talking about safe feeding position, this information is all available on the Epilepsy Action website. The feeding choice should be supported, and advice regarding safety, night feeding and expressing, and try to avoid sudden stop in breastfeeding if taking anti-seizure medicines, because the baby will suddenly withdraw. and provide proactive, holistic, personalised postnatal support. And if you can keep a woman for 42 days rather than discharging her, I'd really appreciate if you do that. And you offer her community care to save her getting up early in the morning for a postnatal appointment. There's lots of resources here. So that's my website, Epilepsy Actions, the first aid poster, safety advice for people with epilepsy. This is the UK Teratology Information Service to give women accurate information about their medicines, the SUDEP and seizure safety checklist, safety and risk on the Epilepsy Society website, and the EPSMON app, and then tips for looking after a baby when you have epilepsy. And as I said, I've helped with this as well. I want to thank you all for listening to me. Hope I haven't overrun, and there's my details if you do need any further support. Thank you.